This is the first of two videos on operative vaginal delivery. In this first video, we will cover a brief historical overview, followed by describing some of the instruments used in operative vaginal delivery, discussing the indications as well as the contraindications. The origin of forceps is uncertain. Certainly there were some discussions of forceps in some of the writings of individuals such as Hippocrates before Christ, but again you should keep in mind that all of these instruments were designed to extract fetuses which were already dead. The first written material appeared about 1000 years AD by Albucasis in the Arabic literature. The instruments that were described have curved teeth jaws and hooks, indicating that they also were designed for post-mortem fetal extraction and destruction. However, what is unique about some of these writings is the actual instruments as shown here were described in this type of detail, again pointing out these were destructive instruments. Through the Middle Ages, there were a number of other authors who described instruments that could be used for operative vaginal delivery, again with dead fetuses. With the development of steel in the 15th and 16th centuries, this became a significant technical advance because, again, the forceps had less weight, tend to be slightly more delicate than iron forceps. However, the challenge remained was designing forceps that would not inflict damage to either fetus or mother in an era where asepsis and transfusion were not known. And it was the Chamberlain family that I think were perhaps the most significant family and in many ways the most interesting family. And they were Huguenots who migrated to England and lived there between 1540 and 1728, and they developed the first major advance, an instrument with a cephalic curve. And here is a diagram of the instrument showing the cephalic curve with the handles and shanks held together with a leather strap. If you look at their basically pedigree, you can see that Peter the Elder was perhaps the individual who actually invented the first of the Chamberlain forceps. All of the male offspring were in obstetrics in one way or another. And in fact, Dr. Peter, noted on the lower left, also even tried to have all the midwives in London be under his command, so to speak, through a guild type association. But the interesting thing about this family is that when they in fact went in to do deliveries, they basically kept the forceps a secret, in that they required other birth attendants to exit the room and the mother to be blindfolded when the device was applied. The secret of the device lasted about 100 years, although various members of the family did try to sell the secret for enormous sums of money. And some of the birthings that occurred with these forceps were in fact with living infants. Numerous advances occurred through the 1700s. Leverett, Smellie, and Pugh developed instruments with a pelvic curve. Smellie also developed a technique for rotational delivery. And in the 1800s, with the discovery of chloroform, as well as some understanding or appreciation of asepsis, again, the morbidity and then the mortality did decrease. And in fact, in 1849, the first vacuum extractor was developed by Simpson, who also was noteworthy for developing a particular class of forceps. This shows a diagram of the Smellie forceps. You can see the lower blade, which is posterior. You can see the pelvic or cephalic curvature on it. This is the initial Simpson air tractor vacuum extractor that he developed, again with a sort of piston that again produced the vacuum for extraction. Simpson was also credited with the development of a class of forceps with parallel shanks. The early 1900s led to the development of specialized instruments and their prophylactic use. Prophylactic use was in the effort to prevent further injury to the pelvic floor, and this was championed by DeLee at the University of Chicago. In addition, Keelan, Barton, and Piper all developed forceps that were specialized. In the 1950s, vacuum extraction was popularized by Malmstrom with his metal cup device, which originally had been developed by Bird. However, starting in the 1970s in this country, the operative vaginal deliveries began their steady decline. From a rate perhaps as high as 30% in the 1970s to a rate that was 9% in 1992 and 3% in 2013. And this is probably a result of much more family-oriented obstetrics as well as better anesthesia and the desire by parturients to have better control of their labors and as well as their deliveries. With any instrument which will be used in patients, however, it is important to know their design and the rationale behind it. So again, knowing what the parts are, I think are important. Forceps are complex levers which can be used for traction and or rotation. Vacuum devices are designed only for traction. And here are the parts starting with the top. You have the toe of the blades, the cephalic curve, the heels, the shanks, the lock, as well as the handles. Notice on the left are the Elliott type forceps where the shanks are overlapping, and on the right are the Simpson type forceps where the shanks are parallel. Again, the Simpson forceps, for example, might be more preferable for a prima gravida with a substantially molded head. And if you look at the lateral view, you can here again see the toe. You can see the fenestration, which again would occur with the Simpson and Elliott devices. You can also have pseudo-fenestration where you have basically a partial sort of dip out of where the fenestration is, as well as solid blades. And then you can see the shank, the lock, and the handle. This is the English lock, which is on the majority of forceps used today, particularly for traction. Notice that this can slide somewhat, which allows one to correct minor degrees of asynclitism. These are the Simpson forceps that he designed, again showing the parallel shanks and the fenestrated blades. These are the Elliott forceps, again oftentimes with a shorter shank but overlapping blades. Here is a Tucker-McLean forceps, which is a modification of the Elliott forceps with solid blades as opposed to fenestrated blades. Here's an interesting forceps developed by Len Lauf a number of years ago, where the lock is in fact at the far end is a pivot lock such that what holds the blades on the baby's head is pressure from the maternal sidewalls, with the idea behind these being that these are ideal for outlet forceps and also reduce the amount of compression that might occur when you exert traction on a fetal head. This is one of the specialized forceps developed by Keelan, and here the superior aspect of the blade is in a straight line with the shank. So again, the blades are somewhat under the shank's plane in somewhat of a bayonet shape. This allows one to rotate a fetus by just twisting the wrists. Notice the two dots on the handles, which allow you to put these blades on with the dots or buttons facing the occiput. Here are the Keelan-Barton forceps, where the lower blade is hinged, which allows you to place, again, the fixed blade posterior and the hinge blade anterior on a head that is in a transverse arrest, resulting in delivery as in a transverse position. This was developed by Lamb and Barton from Plattsburgh, New York. This is a traction handle, which allows one to allow traction in the appropriate vector with less guesswork, particularly for a less experienced operator. Here are the forceps developed by Piper for an aftercoming head. It has a perineal curve, which allows one to put the blades on below the plane of the fetus and allows for easier application. Here is the vacuum that we currently use, which includes a cup as well as a piston device, which again actually produces the vacuum for extraction. So what are the indications for operative vaginal delivery? Certainly they include a prolonged second stage of labor, suspicion of immediate or potential fetal compromise, as well as shortening of the second stage of labor for maternal benefit. All of these indications, again, if appropriate, can reduce the requirement in many instances for a cesarean delivery, which has its own morbidity, as does obviously operative vaginal delivery to some extent. The prerequisites for an operative vaginal delivery include the cervix being fully dilated and retracted, the membranes being ruptured, The fetal head has to be engaged, and you have to know the position of the fetal head accurately, and should have some good weight estimate of the fetus, obviously trying to avoid a significantly macrosomic fetus, as well as good anesthesia. In addition, the maternal bladder should be empty, and the patient has to agree to an operative delivery after being fully informed of the risks and the benefits of the procedure. And also a key prerequisite is the willingness to abandon a trial of operative vaginal delivery and to have a backup plan in place, i.e. a cesarean delivery, in case of failure to deliver, and not to try to persist when in fact there is no progress. Contraindications are fairly straightforward. The fetal head is unengaged. Position of the fetal head is unknown. If you have a live fetus suspected to have a demineralization condition like osteogenesis imperfecta, this would be a contraindication, as well as a fetus with a bleeding disorder such as autoimmune thrombocytopenia, hemophilia, or von Willebrand disease. Inexperience of the operator is a contraindication, and the inability to proceed with cesarean delivery if, in fact, the operative vaginal delivery is unsuccessful. Finally, a gestational age of less than 34 weeks is certainly discouraged with the use of vacuum extraction. This concludes the first of the 2 videos on operative vaginal delivery. Make sure that you also read, or rather view, the second video as well.